Hello, and welcome to today's webinar, A New Model for Engagement, Insights into the Patient Experience at Dana Farber Cancer Institute. I'm Emily Rapley with Becker's Hospital Review. We will begin our webinar today with a presentation, and we'll have time at the end of the hour for a question and answer session with our presenters. Please submit your questions throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. One more quick note before we get started today. Our session is being recorded and will be available after the event. To access the recording after the event, please use the same link you used to log in today. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Naomi Linane is the Chief Information Officer and Vice President of Information Services at Dana Farber Cancer Institute. She was appointed to this role in June 2017. Since then, Naomi has been responsible for all software and infrastructure supporting Dana Farber's clinical and business operations, which includes care delivery, business, administrative functions, and human capital. Prior to her role as CIO, Naomi held multiple roles at Dana Farber, including the IS leader for the Epic Health Record implementation and the opening of the Yawkey Center for Cancer Care. Naomi received her undergraduate degree from Randolph College, formerly known as Randolph-Macon Women's College. Naomi will be joined by Katie Caveney, who is the Vice President of Ambulatory Clinical Operations at the Dana Farber Cancer Institute. Katie joined Dana Farber in 1994 and has served in numerous roles within the organization, focusing primarily in the areas of clinical operations, service line development, financial management, patient access, and patient experience. Prior to entering the healthcare industry, Katie worked as a legislative aide for the Massachusetts House of Representatives, where she focused on public policy to improve healthcare and public safety. She is also a licensed elementary school teacher in the state of Massachusetts. Now, I'm pleased to turn the floor over to Katie to begin today's presentation.
Thank you very much. This is Katie Caveney. Naomi and I are pleased to be here today. We are going to be discussing a new model for engagement, insights into the patient experience at Dana Farber Cancer Institute. So, as we were introduced, I oversee ambulatory clinical operations here at Dana Farber, and Naomi is the Chief Information Officer. So just to set some context, Dana Farber is a Harvard teaching hospital. It's headquartered in Boston with regional locations in multiple areas and collaborations in Maine, Rhode Island, Connecticut, Bermuda, China, Rwanda, and Egypt. We have over 4,500 employees, both full and part-time. We have around 530 faculty members. We have around 350,000 outpatient visits per year, 175,000 infusion treatments per year. We have over 630 registered nurses. Our annual revenue is $1.73 billion. And we have over 1,100 active clinical trials. As we mentioned, we're going to be talking about our journey in the patient contact experience. So the things that we started our journey with, we're really thinking about our patient access and how patients were contacting us here at Dana Farber. Some of the questions we began with were, how do patients get in the door? How many staff do we have speaking to our patients before they even come in for an appointment? What happens when we have multiple appointments or departments speaking to the same patient around the same time? How would we grow our volume without impacting the patient experience? And how do we allow new and existing patients to more easily and consistently access our clinical services across varying different disease centers? Our patient journey here at Dana Farber, we had envisioned it surrounding a centralized hub. We did not have a hub in place. We had a very disparate process. But patients coming in, their journey, they're getting a diagnosis, they're reaching out to us for scheduling needs. We have different clinicians involved in their care. They're getting assessed by nurses. They are dealing with our patient financial services and our billing departments. They may be eligible for clinical trials or treatments that are not available in the communities. So there are many different ways that a patient comes through Dana Farber and different areas in which they interact. So one of the things that we were thinking of through this process is how can we streamline this or improve the process for all patients who are coming in, both new and established. So in early 2017, we embarked on an initiative to really improve the experience our patients, their families, and referring physicians had when they were contacting Dana-Farber. We did this through the configuration of people, process, and technology systems. We had a problem, an existing problem, where employees were unable to answer our patient calls live or keep up with the messages that were coming in. We had many factors that were contributing to this issue, including our staff workloads and the skills of staff, our growing patient volume, our operating model, and we had ineffective technology and tools. In order to determine what we wanted to do, we really needed to assess what our status was. What did our patient contact experience look like at that point in time? As we did an assessment, we reviewed all of our call routing and all of the entry points into Dana Farber Cancer Institute. We had an extremely complex call routing system and multiple entry points with variations of how our operating model and our workflows functioned across 19 different disease centers. This led to caller confusion and repeated information. We lacked the technology architecture to support an efficient operation. We had duplicated systems, we had basic tools, and we had fragmented use of platforms. We were at a point where we had a large portion of our volume that was being supported by an outsourced vendor. They were supporting our overflow patient calls instead of having Dana-Farber employees being able to manage those calls. In order to get a full assessment, we also interviewed patients, their family members, our providers, and staff about their experience with our patient contacts. Through that, it was clear that we needed to plan for a change. In order to do so, we held workshops that were multidisciplinary in nature. We had participants including patients, their family members, some of our top physicians here at Dana-Farber. We had nurses, we had schedulers, we had a real strong cross-section of individuals who played a role in the patient contact experience. Through those workshops, we defined what Dana-Farber's vision was for the patient contact experience. We then developed a roadmap and sequenced a long list of short and long-term opportunities that we could move forward with, and some initiatives to improve the contact experience. We designed a future state patient contact operating model. We identified the need for technology requirements to support the proposed operating model, and we established a future state organizational structure and supporting staffing analysis, including high-level roles and responsibilities. For our organizational design, having gone through the design and planning for change, we needed to test some of the designs that we had created to make sure that they would work within the organization and to see if there were things that we needed to do to tweak before we moved forward and rolled this out across the entire organization. So we established a pilot implementation team and finalized workflows to test the operating models that we had designed. We built the process flow for each patient call type that were coming in. We gathered additional staffing data to support our operating model. And we implemented what we refer to as a patient contact hub that eventually turned into our welcome center. We measured our pilot service levels and refined our processes through this project and evaluated the supporting technology, system, and tools that we required. This slide shows where we began and where we are now. It really looking at how to transform our patient experience from the contact perspective, keeping with the excellence and consistency that we at Dana-Farber pride ourselves on. We needed to have consistency in both the technical and organizational transformations throughout the organization. As you see on the far left, we started in our original state, we were very distributed. We had an outsourced approach where we were having patients reach an external vendor. We pride ourselves here at Dana-Farber of having our patients being one of the priorities and patient experience being one of the main things that we do on a daily basis. So we felt that we were missing the mark by not having our Dana-Farber employees managing these calls. We saw that we had a very disparate process that we had 19 different ways of doing the exact same thing. So we proposed this hub and spoke process where we established a central hub, which once again, that refers to what is now called the Dana Farber Welcome Center. It consisted of in-house Dana Farber employees who would then support the patient contact that was coming into Dana Farber. We had 4 separate pilots that could test this model, one looking at supporting our new patients, one looking at supporting our established patients, trying a new model of how we scheduled to have some cross-coverage and expanded bandwidth within our scheduling teams, and then separating out some of the work so that we were supporting the records procurement for new patients. So we piloted that over a series of months. We had very positive results through that, and we then moved on to where we are now, which is an integrated patient contact center. Through the pilots, at that point in time, we still did not have our technology in place, so we knew that there was still the opportunity for improvements. This slide just shows the pilots and the success that we had just in changing our operating model and changing our organizational structure. We had rapid improvements in certain areas, but it still was not hitting the target that we wanted in creating a consistent experience for patients where they did not have to repeat information, where we could have seamless handoffs, etc. Just from the basic changes that we had made, you can see in the comments at the bottom, patients were really pleased with what we were doing. We had a lot of comments that said, I'm not sure what you changed, but I feel the difference. I feel that I can reach someone. I feel that I'm getting to the person I need to speak with much more rapidly than before. So we knew we were in the right direction. We just needed that supportive technology that really could enable us to move forward at a larger scale. So for our enabling technology, well, as I said, while the revised operating model and organizational structure definitely demonstrated the improvement, we were using Excel spreadsheets, we were using shared documents, etc. to support the work. So we really needed to focus on what we were going to do and where to make that investment in that enabling technology. So here I'm going to hand it off to my friend and CIO, Naomi Linnane.